Evening, viewers, especially to all the nurses. Welcome to our second episode of Critical Care Nursing. And I'm glad that there were a lot of viewers for the first webinar that we have started on critical care nursing, and it is being viewed by many on the YouTube channel. So I'm happy that this initiative has taken a nice takeoff. So today's topic is nursing management of patient on mechanical ventilator. And we have a very nice speaker today. She is Dr. Ujjwal. She is responsible for a lot of nursing teaching in AIIMS, and she's Associate Professor, College of Nursing, AIIMS, New Delhi. So I'm sure all of you find this very interesting and useful because this is, I think, the most important topic, managing the patient on the ventilator. Over to you, Dr. Ujjwal.
Thank you. Thank you, Dr. Tapesh. Thank you for inviting me for the important topic. So good evening to all. And the topic that has been assigned to me is the nursing management of a patient on the mechanical ventilator. So whenever we enter the ICU, everybody, I can say that they would agree the scene or the aura of ICU is like a patient with so many tubings and ventilators, and the patient is very sick. So and a lot of care is required for a patient who is on the ventilator. So if we talk about mechanical ventilation, as I hope everybody is aware, when the patient is not able to take his or her own spontaneous breaths, so we need to give it with an artificial method or with an artificial machine, and it helps to maintain the oxygenation level and the removal of the carbon dioxide for the patient. So everybody has seen this. There are different types of machines that are available. So a mechanical ventilator is a machine that takes over the work of breathing for the patient when the person is not able to do so. And they also control or assist the patient breathing by delivering a predetermined percentage of oxygen to lungs. So all these things will be seen in the settings. So this is just an intro of ventilator so that we get an idea how the patient is on a ventilator and what type of care can be provided. So the invasive mechanical, there are two types of mechanical ventilation, as we all know. It can be non-invasive, like with the mask, or it can be the invasive ones with the endotracheal tubes or the tracheostomy tubes. So endotracheal tube, whenever in the emergencies, and if the respiratory support has to be for a longer period of time, we need to put the patient on the tracheostomy and then provide the artificial support. So it can be through the endotracheal tube or through the tracheostomy tube. So when do we need to put the patient on mechanical ventilation? Whenever there is a continuous decrease in the oxygenation, hypoxemia, the patient may be going into hypoxemia, increased in arterial carbon dioxide levels, PaCO2 levels are keeping on increasing. There may be persistent acidosis, not getting corrected even through the kidneys, thoracic or any abdominal surgeries, any drug overdose, or any type of poisonings, neuromuscular disorders, and in the case of COPDs or respiratory failures. In COPD, sometimes we also need to put the patient on non-invasive type of mechanical ventilation. In cases of multiple traumas, when the patient goes in shock, if there is multi-system failure, if the patient is in coma, apnea that is not readily reversible, or some sort of inhalational injuries. So in all those types of conditions, the patient may require some sort of support for the spontaneous breath, and that can be delivered through the type of ventilation. So basically, we have two types of ventilators, the negative pressure ones and the positive pressure ones. The negative pressure ones were the primitive times when there was a use of an iron cylinder and a negative pressure was generated. So I'm not going to go in detail of all those things. And the positive pressure ventilation, they exert pressure on the lungs of the patient. They inflate the lungs by exerting positive pressure on the airway, and endotracheal intubation or tracheostomy is necessary in most of these cases. So just to have a look of an ventilator, so what are the various parts of a ventilator? There may be a support arm. If we look at number 2, there is an inspiratory port. We have an inspiratory and the expiratory port. We have an active humidifier, so that we do not provide any raw or any dry air to the patient. This is the inspiratory circuit or the inspiratory line with the water trap. So after the evaporation and sedimentation, there is some collection of the water to prevent any insertion. Then at number 5, we have the Y piece. We have expiratory line with the water trap. The 6th one, this is the expiratory line. The 7th is the expiratory port. This is the inspiratory and the expiratory port. The flexible connector. This is the flexible connector with which we connect it to the patient. Then we have the proximal flow pressure sensor, and it may sometimes be also attached with the nebulizer in the in the whole setting, because these patients may be requiring some nebulization as well. So this is the complete circuit of the mechanical ventilation, how it is being provided to the patient. So if we talk about the setting of mechanical ventilator, there are few important things that have to be set, and the nurses should also be aware of those settings. Like first and foremost, like what type of tidal volume has to be given. It is like in the range of 10 to 15 ml per kg for an adult patient. And we have to adjust the machine to deliver the lowest concentration of oxygen. So there is a setting that is FiO2, fraction of inspired oxygen in the mechanical ventilator. We also need to record the peak inspiratory pressure. Then different types of modes of ventilation can be set as per the requirement of the patient and as per the decision of the physician. It may be assist control or ASSC, as well as we also need to set some PEEP, positive and expiratory pressure, to prevent any collapse of the lungs, collapse of the alveoli. We also need to record the minute volume and obtain the ABGs, that is arterial blood gas analysis, to measure the partial pressure of carbon dioxide, pH, PaO2 after 20 minutes of continuous mechanical ventilation. So these are the important things that we observe. We observe for pH for acidosis or alkalosis. We look out for PaO2. We look out for PaCO2 as well as the bicarbonate as well. We also need to adjust the setting of FiO2 and the respiratory rate depending on the condition of the patient. And if the patient suddenly becomes confused or agitated or starts buckling the ventilator due to some unexplained reason, we need to assess for hypoxia, and sometimes we need to remove from the ventilator and manually ventilate the patient on 100% oxygen with a resuscitation bag. So this is the type of TEMA ventilator that is being used in our setting, most commonly being used, and we have many more types of ventilators that are being used these days. So these the types of positive pressure ventilators, they may be volume cycled, pressure cycled, or time cycled. And some of the volume modes are like CV, CMV, ACV, or SIMV, and pressure modes are PSV, CPAP, BiPAP, or pressure controlled IRP. So if we talk about CPAP, they provide continuous pressure through the respiration, even during inspiration and expiration. And BiPAP, that is also a non-invasive technique, and it is used to provide ventilatory support to a spontaneously but insufficiently breathing patient using a face mask or a nasal mask. And it provides two pressure levels during the respiratory cycle, a higher level during the inspiration and a lower level during the expiration. So in the BiPAP mode of mechanical ventilation, non-invasive ventilation, during the inspiration as well as during the expiration, there is a pressure support that is provided to the patient. Then this is the most common mode that is being used these days, and it combines pressure limited expiration. So the IAE ratio is usually 1:2. It may begin from 1:1 and it may progress to 4:1. The patient is on ventilator, what can be the different types of settings, the different types of modes that can be available that you can see in the ICUs. So now the nursing management for those patients on those ventilators. So we are going to discuss one by one all these important management aspects. So first and foremost is regarding the assessment. Suction is very important because the patient is in a most supine position, also semi-Fowler's position. Sometimes high Fowler's position is not recommended or it is contraindicated, and the patient, there is no cough response of the patient. Then the checking of ventilation mode and settings, meeting the patient's physiological needs, providing psychological support to the patient and family, infection prevention, very important aspect. Other lead to the mortality as well as the increased morbidity of the patient may increase, and so many further complications.
Sister, your voice is
Yes,
cracking.
Dr. Tapish?
Your voice is cracking.
My voice is cracking. Okay,
Yeah, you switch off the video, then it will become better. Switch off your video.
Okay, I'll just switch off the video and just try to see if it.
If there's a problem with the bandwidth of the internet, then it becomes a problem sometimes. Yeah, just switch off the video, then I think it will improve.
All right.
Yeah. Yeah, carry on, please.
So we were talking about the nursing management. Yeah, is it okay?
Yeah, now it's okay.
Yeah, okay. So, in the nursing management, so we have to discuss regarding the assessment of the patient condition, the management of the airway, suctioning is very important, checking of the ventilator mode and the settings, meeting the patient's physiological needs, providing psychological support to the patient as well as the family members, infection prevention, infection control, reviewing the communication, prevent hemodynamic instability, monitoring of GI bleeding, and preventing complications of ventilation. So we'll discuss them one by one. So first and foremost is assessment. Once the patient is on ventilator in the ICU, every day in each shift, we need to assess the condition of the patient. So we need to assess the patient's level of pain, anxiety, the sedation needs as well. Monitoring of vital signs, very important. ABC, we have to check for the airway, whether it is clear, whether the ET tube is placed properly as per the sign, whether the ventilator settings are adequate for the breathing. For the cardiovascular system, we need to see the hemodynamic stability of the patient, the cardiac output if it is being recorded, or the central venous pressure, the heart rate. All these things have to be observed. And we also need to assess the neurological status of the patient. I hope everybody is aware in the ICUs. We assess the GCS, Glasgow Coma scaling for the patient. We assess for the level of consciousness of the patient. If the patient is in sedation, we use different scales like RAS to assess the sedation level of the patient. So these are the important things that have to be assessed. We also need to monitor for airway obstruction. Airway obstruction can be because of the falling of the tongue back, or it may be because of collection of secretions, or the patient may be biting the tubes. So there are so many reasons for airway obstructions. We need to observe that. Ineffective breathing pattern. If there are some alarms in the ventilator, we need to see to the alarms whether they are low pressure or high pressure alarms, how the things have to be tackled. So high pressure alarms are usually when there is some obstruction, maybe there are secretions, and low pressure alarms if there is some discontinuation or the kinking of the tube, it may lead to high pressure alarms. So we need to see for the ET tube kinking and other things. We also need to check for the oxygen saturation, right? So we have a probe that has been applied to the patient and we see it on the monitor, listen to the breath sounds and note the changes from the previous findings. And do not always rely on the we have to rely on the monitor, of course, because all the readings are seen on the monitor, the ECG and the other things, but sometimes the leads may not be placed properly, so we need to monitor the patient as well. So along with monitoring of the monitor, we also need to monitor the patient and not only rely on the monitors, because as humans dealing with the humans, it is our responsibility not to become too much robotic and just looking at the machines. We also need to look at the patient. In the management of the airway, we have to assess the respiratory rate and the depth of the patient. So it is through the ventilator. So how much rate has been set and how much is being delivered by the machine. We need to keep a check on that. Assess the patient for oxygenation and sign and symptoms of hypoxia, right? So we can see, let us say FiO2 of 40% is being set and the patient is okay. There are no signs and symptoms of hypoxia, and we need to elevate the head of the bed. And depending on the condition, if there is some contraindication or we need to have semi-Fowler's position, so that has to be maintained. Proper cuff inflation. So I hope everybody has seen an ET tube and it is being inserted and the cuff is being inflated, right? So we need to see that cuff pressure, that it is inflated, and there are no chances that the tube may come out. And the patient is also receiving proper ventilator parameters like oxygenation as well as the complete tidal volume that is required for the patient, that is 10 to 15 ml per kg body weight. And we do not never add air to the cup without using proper techniques, and performing suction and oral care, ensuring the patient get cleared of the airway. Now this is very important aspect. I think it will come separately also, but suctioning and oral care, if it is not being done properly, it may lead to different types of complications. So we'll discuss it there. Providing chest physiotherapy and breathing exercises for secretion, mobilization, another important aspect. So in ICUs, in our ICUs, we have the protocol is that while doing suction for the patient, we also do the chest physiotherapy to the patient. So the physiotherapist comes and chest physiotherapy is being provided by the physiotherapist, and the nurses do the suctioning for the patient, as well as Breathing exercises for secretion, mobilization can also be utilized. So next important aspect is suction. Suction is very important if there are obvious secretions, if there's obvious secretions in the tube, but it has to be done very vigilantly so that we do not provide any trauma to the patient, and unnecessary suctioning should be avoided. So we need to assess the tube insertion site. We also need to assess the breath sounds, vital signs to identify any type of complication. Suction only as needed and notify physician if any change. So earlier it was like every 2 hours it has to be done, but these days it is suction as required. So depending on the condition of the patient, the suction has to be provided. Hyperoxygenation is very important before starting the suctioning procedure. So hyperoxygenate the patient before and after suctioning to help the prevention of oxygen desaturation. These days we have the inbuilt suctioning. We have the concept of open suctioning and the closed suctioning. So in open suctioning, obviously we need to detach the patient from the ventilator and then do the suctioning. Whereas in closed suctioning system, the suction catheter is attached with the ventilator tubings, and we do not need to detach the patient from the ventilator circuit. So, but still we have to see that the patient is hyperoxygenated before starting with the suctioning procedure. Don't instill normal saline solution into the endotracheal tube to promote secretion removal. Routinely, it has been seen that before suctioning, like 2 ml, 5 ml NS is being instilled, but ideally that should not be instilled. It leads to more of damage than any benefit to the patient. Limit suctioning pressure to the lowest level needed to remove any type of secretions. So high pressure will lead to trauma to the airway, and the duration of suctioning should be the shortest duration possible. Maybe it is 10 to 15 seconds. So it is very important aspect, that is the suctioning one. And aseptic techniques, another important aspect. Aseptic technique has to be followed during the suctioning process because it is directly going into the lungs. It is directly going into the lower respiratory tract of the patient. And if not done properly, it may give infections, and the patient may land up into ventilator associated pneumonia as well. Next is checking ventilator settings and the mode. So it is important as a nurse, we also need to be aware what are the settings that has been set and how much is the volumes or the respiratory rate that has been set. Is there any buckling, fighting with the ventilator? So all those things the nurses have to keep in mind and see that the patient is doing well on the ventilator and the condition is improving every day. So read the patient's orders and obtain information about the ventilator. The nurses should be well versed with the type of ventilator that is being used. Earlier, we had the primitive types of ventilator, but these days the ventilators are very sensitive. They sense the effort of the patient. All right. And then the synchronization is done with the machine as well as with the patient. So we have very sensitive ventilators these days to aid in the recovery of the patient faster. So we need to check the type of the ventilator that the patient is on, what type of mode, how much tidal volume has been set, how much breathing respiratory rate has been set, how much FiO2 has been set, what is the IE ratio, what is the inspiratory pressure, peak inspiratory pressure, how much PEEP has been set, and what is the status of the humidification or the humidifier. And as a nurse, we also need to familiarize with the different types of ventilator alarms, like there is low pressure alarm or the high pressure alarm, and what type of action needs to be taken in those types of alarms. Next, we talk about the physiological needs. Just give me a moment.
Yes, please, no problem.
I'm sorry. Next, we move to the physiological needs for the patient. So in the physiological needs, all the needs have to be met by the nurses or by us who are working in the ICUs. So it may be any of the basic needs to any of the high-tech needs. Everything has to be done by the nurses. So if we start from the eye care has to be done. If there is drying of the eyes, then we need to instill some the lubricants in the eyes and keep it covered. Oral care, very, very important aspect. I would like to personally focus on oral care, the most basic and the most neglected aspect in the ICUs. And if oral care is neglected, the flora in the mouth directly travels into the respiratory tract. So it is a most common risk factor. If oral care is not adequate, it will lead to ventilator associated pneumonia. So it is a basic things, and these days we have already in ready to use built chlorhexidine solutions, or the other as per the ICUs it is required, the protocol of your ICU. So we have the solutions. Earlier we had the H2O2, hydrogen peroxide mixed with water, and then the oral care was to be given. But these days, we have specialized brushes, we have specialized solutions that can be used to provide oral care. So it is my request, personal request, that oral care should not be neglected for the patients, as well as hand hygiene should not be neglected. Then moisturizing the lips with the lubricant, maintaining the hygiene of the patient. So this hygiene will include the sponge bathing of the patient, maybe it is hair care or the perineal care or back massage, back care, everything is required for the patient. The next important aspect is the type of feeding. So the patient may have NG feeding, nasogastric feeding, or the patient may have some sort of parenteral type of nutrition. And if NG feeding is there, so the placement of the tubing, the NG tube has to be checked how where it is placed. We need to aspirate whether the gastric contents are there or not, how much amount has to be given, and what is the frequency with what the things have to be given. And if NG is not there, then maybe we are giving through the IV fluids, or the patient may be on TPN. That is total parenteral nutrition. So I hope everybody has seen total parenteral nutrition. So this is again a separate aspect, but aseptic techniques have to be used, and we have to observe for any complications while administering the TPN. Another is address the patient's elimination needs. So elimination needs, the urine output, the patient may be catheterized, or the bowel movements. So the diapers have to be changed, the cleanliness has to be maintained, the perineal care has to be given to the patient, and catheter care also needs to be given to the patient to provide any chances of COTI to develop and the other types of complications. So infection prevention, we are going to discuss on these different types of aspects. Then we have to give a quiet and calm environment to promote rest and sleep for the patient. Very important, because the ICU is working the whole day. The patient is not aware of day and night. The patient may go into delirium. The patient is not oriented to time. So it is our responsibility to provide some quiet time to the patient for promoting their rest and sleep. And keeping the monitor alarm down if possible, but that is important, because if anything goes wrong, the alarm has to be there. Providing dim light at night, and provide patients eyes with the eye patches in the night time. Then comes psychological support. Now, suppose the patient is in ICU, so the patient is the one who is suffering, as well as the family members who are outside. They're also so worried and anxious and tense. What is happening to our patient? Whether there will be any improvement? How my patient is going to revive? So there are so many things that are coming to the patient relatives' minds as well. So we need to provide psychological support to the patients as well as their families. To ease the distress, the patient and family, we need to tell them why the patient has been put on the mechanical ventilator, and what is the need of the patient for putting the patient on ventilator, emphasizing the positive outcome it can provide, why the patient is required, the ventilation is required for the patient. So we need to verbalize all those things. We need to encourage the family members to talk to us, to ask their doubts or some queries, so that they are going to ease. It helps in the recovery of the patient. Explaining the procedure to the patient and family each time, that is very important. Maybe the family is not there in the ICU every time, but yes, when we are doing any procedure to the patient, even if the patient is conscious, or the patient is semi-conscious, or the patient is in coma, still we need to touch the patient, tap the patient, and inform what we are going to do. We are going to do the suction, or we are going to change the position, or we are going to give a feed. So every time the procedures need to be explained. Reinforce the need and reason for multiple assessments and the procedures, and different types of lab tests and the x-rays, why they are important. Every day we need to assess the condition of the patient, whether there is improvement or there is something else that needs to be done. So we need to get all these things every day. Communicate desired outcomes and progression towards outcomes, so the patient and family can actively participate in the plan of the care of the patient. So we cannot isolate the patient from the family. So we need to discuss with the patient, with the family members, what is being planned for the patient for this day, and how do we think this is going to improve in the outcome of the patient. So we have to work as a team, the patient, the healthcare providers, and the family members. So collectively we can progress to provide a better outcome for the patient. And the nurses must be knowledgeable regarding the condition of the patient, the type of ventilation that is being given, and so that the patient and the family members have a faith, they have a trust, they have a confidence in the nurses that yes, our patient is going to get treated well in the hands of our nurses. So another important aspect, very important aspect, I would say, is infection control and infection prevention. So it is a major practice by healthcare personnel to prevent spread, transmission, and transmission of infection between the clients or the patients, from healthcare providers to the clients, or from clients to the healthcare providers. So there may be different types of bacteria that may cause some infections: Staphylococcus, Enterococcus, Pseudomonas, Klebsiella, E. coli, most commonly found bacteria, or some virus, hepatitis B, HIV, hepatitis C, cytomegalovirus, fungal, or some type of the parasites. So if we are not taking care of infection prevention, it will lead to further mortality of the patient, further morbidities of the patient. There will be a longer stay of the patient. The SOFA score, we assess the SOFA scoring for assessing the different vital organs and the infections and the sepsis of those infections. So it is very important to maintain standard safety measures. So as we all know, standard safety measures is a set of infection control practices, and these are used to prevent transmission of disease. They can be acquired by contact, by blood, body fluids, or non-intact skin and mucous membranes. So what is all included in those? Just a review, because this is most important aspect to prevent infection in ICUs. So proper hand washing, the basic technique, but most neglected. So hand washing has to be practiced. Hand rub cannot, it cannot take the place of hand washing. Wearing PPE, very important. Decontamination of our hands, proper waste disposal, the biomedical waste management has to be followed adequately. So we have different colored coded bins these days, and we have puncture proof bins. We have the puncture proof containers for the sharp objects, and how they have to be sent from the ICUs to the proper disposal areas. So one of the most important infection that can occur is COTI, catheter associated urinary tract infections. So the most common causes are again E. coli, Enterobacter, Enterococcus, Klebsiella, Pseudomonas, Candida. And the risk factors: the age of the patient, the gender, females are more prone for UTIs as well, diabetes, the duration of catheter, how many days, the urinary retention or the incontinences, lower professional training of the inserter, impaired immunity. The patients may have impaired immunity because there are so many, the defense mechanisms are being compromised, orthopedic or any other type of neurological problems. So all these factors may put the patient at a risk for development of COTI. So the most important thing in the COTI bundle, we have like hand washing, and we have 5 moments of hand washing. That is very important: before touching the patient, before any procedure, after body exposure or fluid, after touching the patient, and after touching patient's surroundings. So at these moments, we need to practice hand washing. Avoid unnecessary urinary catheters, should never be used unless absolutely necessary. Verify the indication prior to the catheter insertion. These are all the steps to prevent the COTI. Insert urinary catheter using aseptic techniques. Maintain urinary catheters based on recommended guidelines. And perennial care has to be provided. So perennial care has to be provided, that they don't have only catheter every day and every shift. Even if they do not have the catheters, still perennial care is important to prevent any types of infections. And a closed drainage system has to be maintained, and the bag has to be hung on the frame of the bed in the ICUs. The catheter has to be secured properly to prevent any movement or urethral trauma. because while positioning, changing and other things, there may be movement and it may lead to the urethra trauma. Always keep the collection bag below the level of the bladder and not on the floor. So it has to be hanged on the bedside and not on the kept on the floor. Maintain unobstructed urine flow. There should not be any kinking, and empty the collection bag at least every 8 hours or as needed. Do not allow the drainage spigot to touch the collecting container to avoid cross contamination when emptying the follies. So sometimes the hospital attendants may be emptying these bags, so they have to be taught how these bags have to be emptied and not touching the ground or not touching the container in which it is being emptied. Then the collection of specimen also, it has to be done using aseptic techniques, and never take a sample from the urinary drainage bag. It has to be taken from the sampling port. So these are some interventions, care bundles to prevent COTI in those patients. So during the insertion, avoid unnecessary catheterization. All the items have to be used, should be sterile. The equipment has to be sterile. The catheter has to be inserted in a strict aseptic technique. A closed drainage system has to be maintained, and choose catheters of appropriate size. And consider use of antimicrobial impregnated catheters in high-risk patients requiring short-term catheterization from 2 to 10 days. And in the maintenance care bundle, when the patient is on catheter, we have to use aseptic techniques for daily catheter care. Hand hygiene is important. Sterile items as well as equipments have to be used. Closed drainage system should not be broken. If urine specimen collection is required, take the specimen aseptically via the sampling port, and do not insert some sort of infection while taking the sample. Keep the drainage bag above the floor but below the level of the bladder to prevent any reflux or contamination. And review the need for the catheter on a daily basis. Remove catheter promptly when no longer it is necessary. So these are the bundle. So I hope everybody knows bundle is a set of interventions, a set of evidence-based interventions to prevent any type of complications. So these are the bundles that are being used in our hospital. So we have a bundle for epilepsy, we have a bundle for COTI, we have a bundle for VAP. So in the epilepsy, that is the arterial line infections or bloodstream infections. So first and important is hand hygiene. Maximum barrier precautions have to be used, practiced. Skin aseptic techniques have to be used. Transparent dressing has to be applied on the site. Daily reviewing the line site, and early removal or early sign of phlebitis have to be observed. COTI we already discussed. Then VAP. VAP, as I hope everybody must be aware, VAP is ventilator associated pneumonia. It may occur from 48 to 72 hours of intubation, mechanical tube intubation, and there may be the patient may present with fever, or there may be a new chest infiltrate, or there may be a bigger chest infiltrate. Along with there can be biogas degradation, gas exchange degradation, or there may be pleural secretions. So these are the indications that the patient may have VAP. So to prevent the VAP, very important, we have to elevate the head end of the patient 30 to 45 degrees. Aseptic techniques have to be maintained. Oral care, very important aspect. Suctioning has to be done in a sterile way. Sedation vacation has to be assessed. In our setting, early morning, every day, sedation vacation is being assessed. DVT prophylaxis has to be provided, and weaning protocol has to be assessed. And another is the Ramsey score, that is for the level of sedation. We assess for the anxiousness or the agitation. We assess whether the patient is cooperative, oriented, or on tranquilizers, responding to commands, and brief response to stimuli. There is sluggish response or no response to the stimulus. And the ABC here is like we have the different shifts. So morning, evening, and night. So we usually mark them as ABC. So every shift, all these bundles have to be adhered to. The next aspect is review communication. So we have to assess the ability of the ventilator dependent patients to communicate, like how much they can communicate, whether they can tell about their condition, if they are having pain, or they are not able to lie properly, or their position is not proper. Then we also need to alert some non-verbal clues of the patient and non-verbal methods of the communication. So we may ask You can raise your hand, or we can have a communication board made for those patients, and they can just point on those communication board what is their concern, what is their problem, and the need can be addressed to. We can provide with writing tools or communication board or some sort of bell the patient can express their needs, or we can simply ask them to nod their head while shaking yes or no. Now another important aspect is preventing hemodynamic instability. So hemodynamic monitoring is very important. All the devices that are connected to the patient have to be monitored regularly. We need to assess the patient's blood pressure every hour. So all these important vital signs, they are monitored every hour in the ICUs. I hope everywhere it is being done the same. And if some setting has been changed, the ventilator or adjusted, then again we need to monitor all these things more frequently. So to maintain the hemodynamic stability, maintain IV fluids or administer drugs such as dopamine or epinephrine if the doctor has ordered. If there is some low BP or some other condition and the patient has been prescribed some sort of drugs that have to be given. High levels of inspiratory pressure with PSV and PEEP increase the risk of barotrauma and pneumothorax. So that is why I discussed, to prevent any of these complications, we have the pressure support modes these days, but the ventilators are very sensitive to prevent any complications of barotrauma or the volume trauma. We also need to assess these complications and often check breath sounds and oxygenation status. Now, prevention of complications from the ventilators, because in the beginning we had seen the setup of a ventilator. There are so many inspiratory circuit and the expiratory circuit, and there are so many tubings in between. So there are so many chances that there are some complications that can be given to the patient. So washing of hands, using of appropriate personal protective equipment is very important, and keeping the head of the bed elevated. It is even in the BAP bundle if the patient condition allows. Oral care, again, very important. Observe the skin for any sort of pressure sores. Assess for the risk of development of pressure sore using the Braden scale. Providing back care, use of pressure relief mattress, and the change of position frequently. The patient is also at a risk of developing deep vein thrombosis. So we can have an intermittent compression device. So at the bedside, we may have the DVT pump or the other type of devices. We can practice the range of motion exercises and patient turning and repositioning to prevent the effects of muscle disuse. We also need to monitor for the GI bleeding, monitor the bowel sounds, monitor the gastric pH and hematemesis gastric secretions every shift. So like we were discussing, the ventilator may give some alarms. They may be high pressure alarms, they may be low pressure alarms, they may be low exhale volume or the rate or apnea or FiO2 alarms. So if it is high pressure, so the pressure required to ventilate exceeds the pressure that has been set. And the potential causes can be pneumothorax, excessive secretions, or decreased lung compliance. If it is low pressure, so resistance to the inspiratory flow is there, then the set pressure, there may be disconnection in the ventilator, or there may be some break in the circuit. If there is low exhaled volume, so exhaled tidal volume drops below the preset amount, and there again may be some leak in the system, increased airway resistance, or there may be decreased lung compliance. If there is some alarm for the rate or the apnea, the respiratory rate drops below the present level. Apnea period exceeds the set period or the set time. So there may be client fatigue, or there may be decreased respiratory rate due to the medications or some sort of drugs. For FiO2, it indicates some FiO2 drift from the present range. Maybe it is high or it is low. So there is change in the level of consciousness of the patient. There may be disconnection from the oxygen source or break in the circuit. So these are the different types of alarms that are given by the ventilators and the potential causes for those alarms. So there can be some other complications associated with the ventilator, like in the airway, there may be aspirations. There can be decreased clearance of secretions if the sectioning is not being done properly, positioning is not being done properly, the chest physiotherapy is not done properly. So the patient may still have the secretions, and it may lead to some airway complications. They can be nosocomial or VAP, ventilator associated pneumonia. In the mechanical causes, there may be hypoventilation or there may be hyperventilation. There may be barotrauma to the patient, failure of alarms on the ventilator. So it is very important to observe the patient also. Inadequate humidifications can be there. Overheated inspired air resulting in hyperthermia. So these are the different types of complications. In the physiological complications, due to ventilator, the patient may have hypotension and decreased cardiac function. There may be stress ulcers. There may be gastric distension. There may be paralytic ileus, as well as there can be starvation in the patient. So these were the basic care of a patient on the ventilator. So once we are talking about the ventilator, the patient also needs to be weaned from the ventilator. So we'll just have a discussion, short discussion on the weaning from the mechanical ventilator. So weaning is gradually removing the patient from the ventilator and restoring the spontaneous breath or breathing after a period of mechanical ventilation. So usually the weaning mode is the SIMV, synchronized intermittent mandatory ventilation. The patient can be then put to PCV, T-PACE and CPAP, and then to the room air. Mask, then to the mask, and then to the room air. So in the clinical criteria for weaning, we need to see the resolution of the acute phase of disease. So whether there is adequate cough response from the patient, there is absence of excessive secretions, and the patient is stable hemodynamically and cardiovascular parameters are also stable. In the ventilatory criteria, if we look at, we have to see that the patient is able to tolerate SBT, spontaneous breathing trial for 20 to 30 minutes. The PaCO2 is maintained less than 50. Vital capacity is more than 10 ml per kg. Spontaneous tidal volume is more than 5 ml per kg. And minute ventilation is less than 10 liters with satisfactory ABGs. So all these ventilatory criteria has to be fulfilled before starting with the weaning for the patient. And oxygenation, we have to see that PaO2 is more than 60 without PEEP, and if it is with PEEP, it has to be around 100, and saturation also has to be maintained more than 90%. And pulmonary reserve vital capacity has to be more than 10 ml per kg, and the other measurements have to be in range. So these are the different criteria that are required for the weaning of the patient from the ventilator. Now, because if it is a nursing session, so we usually discuss nursing management in the terms of nursing diagnosis and the nursing interventions. So after the assessment, we frame some of the nursing diagnosis. Like this is the nursing diagnosis, and these diagnoses may change every day as per the condition of the patient. And nursing intervention, what are the steps or what are the things that have to be done in those types of diagnosis to provide comfort to the patient. So, so the first diagnosis, there may be inadequate gas exchange due to the disease process or debilitated state or the fatigue. So we have to auscultate the breath sounds. We have to assess the wet, noisy respiration, restlessness, the visible secretions in the ventilators. Positioning has to be given. Chest physiotherapy has to be given. Suctioning only when the rhonchi is auscultated, and the pressure should not exceed 100 to 120 mmHg in the case of an adult. And for the pediatrics, it is less. Observe the secretions for any change in the consistency and color. And changing of the saline solution, like while suctioning, we have the saline bottles. So that has to be changed. It depends on the protocol of the ICUs or the protocol of the hospital, whether the bottle has to be changed every shift or every 24 hours. The suction catheters have to be ideally used every time, they have to be used fresh. So all those things have to be done as per the protocol of the hospital in which the person is working. Follow strict aseptic techniques. Monitor the hydration status of the patient to prevent any viscous secretions. But that will also depend upon the condition of the patient, if the patient is having some cardiovascular problem or the renal problems. So the hydration status, how much fluid has to be given to the patient, that also depends on the prescription, depending on the status of his cardiovascular status and the renal functioning of the patient. Administer nebulization as prescribed. There may be some sort of, maybe some bronchodilators or some steroids that may be helping the patient with the effective gas exchange. Then we also need to monitor the ABGs 10 to 30 minutes after the ventilator changes occurs. We need to check for the pH, PaCO2, PaO2, and the bicarbonate levels. We also need to monitor the saturation during suctioning or any other type of procedures, even during even during the positioning or even during monitoring any devices. So every time the saturation has to be monitored. And we have to see whether some specific type of position may lead to some decrease in PO2 or respiratory discomfort. So that has to be avoided. We have to assess for the signs and symptoms of hypoxia or hypercapnia, assess the patient's respiratory rate and depth. Bilateral and air entry has to be assessed every day by auscultating the lung sounds, both the sides. Monitor for any respiratory distress, the nasal flaring, or the excessive effort of the patient. Monitoring the ventilator settings and the proper connection of the tubings, and providing adequate and humidified oxygen to the patient. Then we need to assess another nursing diagnosis can be like decreased cardiac output related to some blood loss or compromised myocardial function. So we have to assess for the blood pressures. There may be NIBP, non-invasive blood pressure monitoring, or there may be IABP pressure monitoring. So those has to be monitored. Arterial blood pressure every 15 minutes until stable, and then every 8 to 12 hours until hospital discharge, and then every visit. Auscultate for heart sounds and the rhythm. Observe for the ECG on the monitors. Early identification is the key. I hope in the previous session, the concept of ICU, the principles would have been discussed. So the early identification of any problem is the key. Assess for peripheral pulses, monitoring of ECG for any sort of cardiac dysrhythmias. Assess for any cardiac enzyme test if they're available, monitoring the intake and output, observe for any persistent bleeding, or any if there is requirement of the administration of some blood products or IV solution that has to be prepared, observe for any cardiac tamponade or any type of hypotension in the patient. The patient may have fluid volume deficit related to alternation in the blood volume. So we need to maintain the fluid and electrolyte balance for the patient. The intake and output sheet has to be filled every hourly. It has to be monitored. Blood pressure parameters have to be monitored. Measure if the patient is a post-operative, then we have to see for the chest drainage. Be alert for the changes in the serum electrolyte levels as well. There may be impaired tissue perfusion. So we need to assess the vital signs of the patient. We need to assess the peripheral perfusion, input and output, oxygen saturation, and NIBP, and perform hemodynamic monitoring with each change in the PEEP settings. Hyperoxygenation or hyperventilation prior to suctioning is required if it is open suctioning. If it is closed suctioning, maybe the setting it is there in the ventilator and the patient is still attached with the source of oxygen. Assess for peripheral circulation or for color, temperature, capillary refill time, and numbness, and provide oil massage to the extremities if required. Then the patient may also complain of pain. So sometimes the patient may be able to complain of pain, but sometimes the patient may be in a delirious state, not able to complain. So we have to assess through the behavioral tools also for assessment of the pain. We can use a visual analog scale if the patient is not able to talk, and the patient can mark how much pain the patient is having. So maintain tube positioning to prevent any pulling or jarring of the TT tube. Provide comfortable position to the patient. Administration of analgesics as prescribed. And non-pharmacological modalities can also be used if the patient is able to understand them or comprehend them. Another important aspect, the patient may have impaired skin integrity because the patient is lying on the bed, not able to move. There may be pressure exerted on the high pressure areas, maybe on the sacrum, on the scapula, on the shoulders. So the skin integrity may be impaired. We need to assess the skin for any redness or wound or lesions. We also need to assess the severity of the pressure sore or the risk, how much risk the patient has for development of the pressure sores. Positioning changes is required. We can use comfort measures, comfort devices like air mattress or the water mattress, and cleaning the wound area with sterile gauze and applying the antiseptic dressings. Massage the area regularly with the oil, or depending on the protocol of the ICU, whether it has to be cleaned with oil or with spirit or just with powder. So those has to be practiced. The patient may have altered bowel pattern related to the NPO status and immobilization. So we need to assess the elimination pattern. Maybe the patient is having diarrhea or constipation. Assessment of bowel sounds is important. High fiber diet, depending on what type of diet has been prescribed for the patient. Administer fluids as prescribed. Perineal hygiene has to be provided. And stool softener can be given in the ICUs because sometimes the patient may be constipated, and that can again lead to discomfort in the patient. Imbalanced nutrition, of course, because the patient is not able to eat and the metabolic requirements increase when the patient is on the ventilator. So we need to weigh the patient. Sometimes weighing of the patient daily is not possible, but in our setting, we do have some beds in which we can take the weight of the patient when the patient is on the bed itself. So the type of diet we make provide with high calorie diet using the tube feedings or TPN, and we have to avoid high carbohydrate load because it can lead to PaCO2 levels during the weaning process. So oral feeding is always enteral feeding is always preferred over the parenteral feeding. So when and where the patient can be able to tolerate that, oral feeding can be starting depending on the prescription from the physician treating. Monitor the intake and output, monitoring the lab values and the serum electrolyte values. Oral hygiene, again, even if we do not do our oral hygiene, our gastric status or the nutrition status is imbalanced. So it is important to provide oral hygiene. We have to assess for the evidence of GI bleeding, whether in the vomitus or in the stool. Supplement vitamins and minerals as prescribed. The patient may have altered sensorium because of sedation and the environment of the ICU. So we need to orient the patient according to the time, place, and person. Like every morning shift, can say, hello, today is this date, this day, right? Document the GCS scoring of the patient and explaining all the procedure to the patient and switching on and off the lights according to the diurnal variation, like in the daytime and the nighttime. Another important risk diagnosis is risk for infection, right? So as we discussed, hand washing is very important. So hand hygiene before and after touching the patient and his surroundings, changing of the tube, exhalation valve and humidifiers of mechanical ventilator periodically, discarding any drain or condensate that collects in the ventilator tubings, sterilizing the reusable breathing circuit between the use of different patients. That depends whether we are using a fresh for all the patients or we are still using the sterilized reusable breathing circuits, and use sterile water for to fill the humidifiers and the ventilators. Aseptic techniques during suctioning, changing of the dressing of the central line daily using aseptic techniques. So that also varies. In some hospitals, the dressing is changed every day. In some hospitals, it is changed 48 hourly. So that depends on the protocol of the hospital. Sending the culture of urine, blood, and sputum, and check the lab result to find out if there is any sort of infection. Using sterile technique to change the dressing of post-operative site incision site. Check the site of insertion of drainage for any kind of redness, warmth, or oozing of pus, and maintaining the closed system during the suctioning. Then obviously the patient is self-care deficit, and so all the care has to be provided: oral hygiene, bed bath, hand and feet nail care, comfort devices for the well-being of the patient, perineal care, hair care, eye care, back care. So all those things have to be provided to the patient. Impaired verbal communication because the patient is the ET tube, so we need to explain the procedure. We may keep a call bell nearby. We can provide some pencil or pen if the patient is able to communicate with that, or we can have some signboard. Reassure the patient that voice will return once the ET tube is removed, and there may be pain in the throat as well because the tube is still lying in the throat. So the patient has to be reassured that the pain will subside once the tube is out. The patient may have so much of anxiety, even if in small NG tube, the diameter of NG tube is much less. Even that causes pain in the throat. So ET tube again, it may lead to pain in the throat as well. Anticipate and support patient during the period of anxiety and frustration. The patient may have at a risk of injury, so we have to put the side rails always on the side of the bed on, and we should observe the patient from the counter as well. Restrain the patient to prevent self extubation only when prescribed. So restraining is uh, not appreciated or not in the protocols these days, but in few patients, after taking the consent and as per the protocol, some patients may be required to restrain because they may be very much fighting with the ventilator and pushing the tubes. Sedate the patient as prescribed. And sometimes if the patient is not able to survive, then we have to provide with the end of life care to the patient. checking the death declaration form, removing all the tubings, plugging all the orifices, cleaning the patient, giving sponge bath, tying the extremities with bandages, covering the body, putting up the identification tags, and then handing over to the patient's family gracefully. So, into the important aspects for today's sessions were like aseptic technique in most of the procedures, mouth care, very important, then elevation of the head of the bed, and consider using subglottic secretion drainage ET tubes. So, in some hospitals, we may have the ET tubes with the subglottic secretion. As a little small tube is attached with the endotracheal tube. So, that type of secretion also helps in preventing the VAP and other types of complications, providing stress ulcer prophylaxis, support proper nutritional status, monitor the ventilator settings and patient responses, and perform suctioning. So these are the important aspects that are done for the patient in the ICUs. Actually, a lot of things are being done for the patient in ICUs. It is very hectic in the ICU because every time and then something or the other is being done for the patient, and there is some procedure, some drug, or some care the patient has been given. So we also need to plan the activities so that we also provide some rest time to the patient and not always engaging the patient in some or the other activities. So that also has to be taken care of. So to conclude, nurses caring for patients on mechanical ventilation require specialist knowledge and skills to monitor, identify, and prevent the potential deleterious effects associated with it. So the nurses working in the ICUs have to be very vigilant, have to be very active, and have to be very. They should have be able to. They should be very keen observer to see the patient and their conditions, and they should be able to comprehend. They should be able to identify any type of problem that is happening. So a nurse in ICU is has to be very active so the outcome of the patient can be improved. So with this, a few of the references, and thank you for the session. Thank you, Dr. Tapesh.
Thank you, sister. That was an excellent talk on mechanical ventilation, the nursing care that is associated with it. So please stop the share screen, sister.
Yes, I'll stop sharing. Yeah.
So viewers, if you have any questions, please put them up. We'll be happy to answer. Just a few points from my side as a doctor, as ICU physician. One, you have to be very careful when the patient is on the ventilator, and the few things are: one, you should take care of the tube, right? The tube should not become loose and come out. So whenever you take over, make sure the tube is secure. Second, you have to make sure that there is no self-extubation. That is another problem because these both things lead to mortality. If the tube comes out or if the patient self-extubates, and most of the time the patient self-extubates when he is going to be weaned off. When you switch off the sedation and he's getting up, because that time he is regained from his illness and he is capable of pulling out the tube. So you have to be very careful. Third is the VAP bundle. VAP bundle, strict aseptic precautions have to be followed. Otherwise, development of VAP is a very big problem. And fourth is the alarms. So when the ventilator gives the alarms, please inform the ICU doctor. Whatever you can do, please do. Otherwise, sometimes these things have to be managed by the doctor only. So please inform him. Don't ignore the ventilator alarm. So these are the few things. Of course, there are many other things, but these are the things which lead to direct problems in the ICU and have to be tackled. Rest is all okay. She has said very nicely. Really thank Dr. Ujjwal for the excellent lecture and the lecture series we have started for nurses all over our country. So we'll put this up on our YouTube channel. The first one is already there. Many of you have seen that, taken by Sister Cindy. So this will continue every month, and I'm sure this will help all the sisters across the country. So thank you, Sister Ujjwal. There are no questions. I think we can close the session. If you have anything to say personally, please go ahead.
Yeah, thank you, Dr. Tapesh. And I think it is a very good initiative, and it is going to help the patient outcome as well as the nurses who can self-empower them with the knowledge that can be provided through this platform. So thank you so much.
Yeah.